Welcome back, aspiring nurses. Get ready to step into a real-life nursing scenario made just for your next-gen NCLEX-RN prep. And in this interactive case study, you'll practice thinking like a nurse, spotting important clues, deciding what to do first, and checking if it worked. It's all about building your clinical judgment skills so you feel more confident both for the NCLEX and on the job. Let's get started.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere, at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
And here's our first test item. This is a bow tie. The clinical case scenario here says a 62-year-old male presents to the emergency department with complaints of substernal chest pain radiating to his left arm for the past 3 hours. He describes the pain as a heavy, squeezing sensation, rated 7 out of 10 in intensity. The pain is associated with nausea, diaphoresis, and shortness of breath. He denies recent trauma or injury, but reports intermittent chest discomfort over the past week, relieved by rest. Now let's go into the vital signs on admission. It's showing us that the temperature is 36.8 degrees Celsius, heart rate of 92 beats per minute in sinus rhythm, respirations of 22 breaths per minute, blood pressure of 158 over 94, and oxygen saturation at 94% on room air, and improved to 98% on 2 liters per minute oxygen. And the pain level is 7 out of 10 pain. Now let's review the rest of the medical record here on page 2. We have the admission details with the time of arrival around 8 in the morning via ambulance accompanied by the spouse. And the initial complaints include substernal chest pain, nausea, diaphoresis, shortness of breath. And the pain again is about 7 out of 10, heavy, squeezing, radiating to the left arm. And the oxygen level is about, the oxygen given is about 2 liters per minute via nasal cannula with IV access. Also 12 lead ECG, nitroglycerin sublingual, where the initial interventions provide for this patient. Now let's take a look into the rest of our medical record here. We have the medical history details. The patient has a history of hypertension diagnosed 10 years ago, type 2 diabetes 5 years, and then he had appendectomy back in 1995. Currently takes lisinopril 20 milligrams daily, metformin 500 milligrams twice a day, aspirin 81 milligrams daily, and smokes a pack per day for 30 years, occasional alcohol use, retired mechanic. Those are the information on his social history. And family history includes father died of myocardial infarction at age 65. Let's move forward to the medical record here. We have the following lab results with the initial results of troponin. This is 0.8 nanograms per ml. CKMB of 12 nanograms per ml. BNP of 250 picograms per ml. Hemoglobin of 13.8 grams per deciliter. Hematocrit of 41%. Potassium of 4.2. Sodium of 138. creatinine of 1.3 milligrams per deciliter, and a blood glucose of 180 milligrams per deciliter. Now let's take a look into the other details here with the following diagnostic test and results. So the 12-lead ECG showed ST segment elevation in leads V2 through V4 with reciprocal ST depression in inferior leads 2, 3, and AVF. And the chest X-ray shows mild cardiomegaly, no evidence of pulmonary edema or pneumothorax. And the echocardiogram has been ordered to assess for left ventricular function. Currently, their results are pending. Now, let's take a look into the nurse's progress notes entered around 8:30 in the morning. It says, patient arrived in emergency department via ambulance. Complaints of chest pain, 7 out of 10. Nausea, diaphoresis, shortness of breath. Oxygen started at 2 liters per minute. IV access obtained. Nitroglycerin, 0.4 milligrams sublingual administered. 12-lead ECG completed. Shows ST elevation in V2, V4 with reciprocal changes. Awaiting cardiology consult for possible catheterization. So, I want to make sure that you have reviewed the entire medical record for this patient. And so you can pause this video right now and you can rewind it to that point where you want clarification. Now let's proceed. So the instruction for us to do in this test item is to drag and drop the options into the appropriate sections of the bow tie diagram. Select one condition, 2 actions to take, and 2 parameters to monitor. So I want you to make sure that you assign all these choices into the correct spots. Now let's look into the choices for the potential condition. We got the following. Type A, aortic dissection. We have acute ST elevation, myocardial infarction, or STEMI. We have non-ST elevation MI. We also have acute pulmonary embolism and acute pericarditis with effusion. Now, for the nursing actions, the following are, the choices are: administer heparin 5,000 units IV bolus immediately, obtain chest CT with contrast to rule out aortic pathology, administer nitroglycerin 0.4 milligrams sublingual if blood pressure remains above 90 systolic, administer metoprolol 25 milligrams orally to reduce heart rate, administer oxygen 2 liters per minute via nasal cannula to maintain saturation equal or greater than 95%. Now, for the parameters to monitor, we got the following options: blood glucose every 4 hours, serial troponin I levels every 6 hours, jugular venous distension every 30 minutes, chest pain intensity and response to nitroglycerin every 15 minutes, and new onset ST segment changes in additional ECG leads. All right, so I hope that you're ready to fill in the blanks this time. So just to give you some hints here, in order for you to correctly answer this question, I want you to recognize first the cues by identifying the critical findings that you have gathered. And then you will analyze the cues and prioritize hypotheses to confirm the potential condition over the distractors using the ECG result and the laboratory data that you have scanned. And then after that, you need to take action by selecting those 2 nursing actions and evaluating those outcomes by those 2 appropriate parameters to assess the effectiveness of those 2 nursing interventions. Now, let's start filling the diagram here. So the condition for this test item is acute elevation MI. Acute ST elevation MI, I should say. That's STEMI. And why is this the correct option? Well, based on the patient's symptoms, he reported chest pain 7 out of 10, nausea, sweating, we call that diaphoresis, There's also some shortness of breath. These are all signs of a heart attack. Now, the ST segment elevation on the ECG in leads V2, V4, and the reciprocal ST depression in other leads support the diagnosis of MI, especially STEMI, which means there's a blockage in a major heart artery. In addition to that, the elevated levels of troponin and CKMB show that heart muscle damage, and it also confirms the heart attack. Now, I want you to go back into the patient's risk factors. He had a history of hypertension, diabetes, smoking. So these will increase his chance of having heart disease that led to this heart attack. And so, keep in mind, the condition here is acute ST elevation MI. Now, let's look into the other options that are incorrect. So, the one that I would pick this time would be the non-ST elevation MI. Why not this option? Well, remember that non-STEMI can also cause chest pain. It can elevate heart enzymes. But the ECG would show different changes, like ST depression or maybe abnormal T waves, not the clear ST elevation seen in this patient. And since this patient has the ST elevation on the ECG, then it indicates STEMI, not non-STEMI. Now, what about the acute pericarditis with effusion? Well, this condition typically causes sharp chest pain that is worsened by movement or deep breathing, not characterized by heavy squeezing pain that radiates to the arm like this patient has. And in addition, the ECG and pericarditis show widespread ST elevation across many leads without reciprocal changes that you're seeing here. And the patient's chest pain and ECG findings are more typical of STEMI. Now, let's look into the acute pulmonary embolism. Why is this incorrect? Well, remember that with PE, it happens when a clot blocks a lung artery. It can cause a chest pain, there's difficulty of breathing, and sometimes tachycardia. However, the ECG changes that you're going to see in PE are different. They can show signs of right heart strain or right ventricular strain. There's not going to be ST elevation like you are seeing in this patient. And the patient's symptoms and ECG findings don't really match PE as you're suspecting. So it's not the right diagnosis in this case. Now, we also have the type A aortic dissection. Why is it incorrect? Well, this condition involves a tear in the main artery of the heart, and it causes severe tearing pain that will often move to the back, along with the other signs like unequal pulses. Now, the ECG for the aortic dissection typically would not show ST elevation like this patient's ECG, and this patient's symptoms and the heart enzyme levels point more toward STEMI, not type A aortic dissections. Now, let's move on into the nursing actions. So what are these two correct answers? So the first one that we are going to select here is administer nitroglycerin 0.4 milligrams sublingual if blood pressure remains above 90 systolic. Now, why is this correct? Now, I want you to recall that nitroglycerin helps the heart vessels. It can actually relax. It can widen the heart blood vessels, which will reduce the strain on the heart, and it helps get more oxygen. And this patient has high blood pressure, so using the nitroglycerin will help manage the blood pressure. It will relieve the pain caused by the heart attack. However, we only use nitroglycerin if the patient's blood pressure is above 90/60 to avoid making it too low, or we don't want hypotension to occur in this patient. The next intervention that you should select here is to administer oxygen 2 liters per minute via nasal cannula to maintain saturation of greater or equal to 95%. Now, the patient's oxygen level, which is 94, which is a little low, and since he has some shortness of breath and chest pain, we want to increase the oxygen supply to his heart and other organs to help prevent more damage. And we're going to give oxygen through a nasal cannula at 2 liters per minute, and this will help improve his oxygen level and support his heart function during this heart attack. Now, let me just go back real quick into our first nursing action, which is the administration of nitroglycerin. Well, in this case, the nitroglycerin is not primarily indicated to relieve the chest pain. What it's supposed to do is to reduce the preload. It will cause vasodilation of the peripheral blood vessels, so it will reduce the blood flow back to from the peripheral circulation back to the heart. So meaning it will decrease the rapid return of venous blood to the heart. So it will not be overwhelmed by the current blood volume. And it can also decrease the afterload. There's going to be a decrease in the systemic vascular resistance. And that's the reason why nitroglycerin is still being used in such a case of ST, MI elevation. All right. Now let's look into the different or the other nursing options that are incorrect here. So if you selected metoprolol, administer metoprolol 25 milligrams orally to reduce heart rate. We know that this is a beta blocker. This is used to lower the heart rate and blood pressure in some patients with heart attacks. However, they are not usually given immediately in the emergency department for STEMI because they can lower the blood pressure too much before the heart gets enough oxygen from the treatments like reperfusion, or let's say opening the blocked artery. And since this patient's heart rate is 92 beats per minute and it's not dangerously high, giving metoprolol right now could be risky. Now, if you selected obtain chest CT with contrast to rule out aortic pathology, well, a chest CT is typically done if there's a suspicion of an aortic dissection, which is a tear in the main artery of the heart. However, this patient's symptoms and ECG findings already point to STEMI, not an aortic issue. So we got to focus on treating the heart attack immediately, not delay things by doing a CAT scan. Now, if you selected administer heparin 5,000 units IV bolus immediately, this is supposed to thin the blood and prevent new clots in patients with STEMI, but it's usually given after the patient has been stabilized, and plans for interventions like reperfusions are already set. And so giving a large dose of heparin too early could actually increase the risk of bleeding before the necessary treatments are completed. Now let's move on to the parameters to monitor. So make sure that you selected those 2 correct options. So the first one that we have is to monitor serial troponin levels every 6 hours. So we know that troponin is a protein that is released when the heart muscle is damaged, and its levels increases after a heart attack. And so checking it every 6 hours helps to see if the heart damage is getting worse, and it also helps the treatment decisions. Now, the other answer that we have is to assess the chest pain intensity and response to nitroglycerin every 15 minutes. And remember that the patient's chest pain is 7 out of 10 and indicates significant heart stress. So when you're monitoring his pain level frequently, especially after administering nitroglycerin, it will help you to see if the treatment is working and if we need to take further action to relieve his pain. Now, the rest of the other options are incorrect. So if you selected monitor new onset of ST segment changes in additional ECG leads, well, although ECG monitoring is important, this patient already has clear signs of STEMI from the initial ECG. So there's no need to keep checking for new ST changes right now. What you need to do is to focus more on monitoring his troponin levels and pain, which give us more helpful information about this condition. Now, if you selected to assess jugular venous distension every 30 minutes, that sounds quite a bit much. So we know that JVD, or jugular venous distension, is a sign of heart failure. But this patient's primary issue is a heart attack, not heart failure. And so the focus here should be on monitoring his pain and heart enzymes, not JVD. Now, this time, if you have selected monitoring blood glucose every 4 hours, that's also incorrect. We know that his blood sugar was about 180 milligrams per deciliter, which is slightly elevated. And this is typical for someone with diabetes, but this is not the priority at this moment. The main concern that you should manage is the heart attack. So you need to focus more on his pain and the heart markers like troponin and the CK-MB. So I hope that you're able to capture all of those correct answers and disregard those distractors. Good job. Let's have our next test item. So this is a multiple response grouping test item. So let's go back into our case scenario. Looks like we have an updated scenario here. It says the patient reports that chest pain reduced to 5 out of 10 after nitroglycerin. Vital signs: blood pressure 150/90, heart rate 88 beats per minute, respirations 20, saturation of 98% on 2 liters per minute, and oxygen. We got troponin I is 0.8 nanograms per ml, and ECG shows persistent ST elevation in V2, V4. Cardiology has recommended urgent PCI, and the patient is awaiting transfer to the cath lab. The patient is anxious and nauseated. Select the appropriate interventions for each category to manage the patient's condition and prepare for the PCI. So, let's move into the nurse's practice notes. I don't want you to miss this. So around 9 a.m., this was entered by the registered nurse. We are seeing that it says patient reports slight relief of chest pain 5 out of 10 after nitroglycerin. Vital signs 150/90, heart rate 88, respirations 20, saturation 98 on 2 liters per minute, O2. Cardiology consult recommends urgent percutaneous coronary intervention. Awaiting cath lab availability. Patient appears anxious and reports persistent nausea. Now, this time, your task is to select the interventions that belong in each category, and each category may have multiple correct answers. So let's take a look into the different categories. We got pain and symptom management, preparation for percutaneous coronary intervention, or the PCI, and ongoing monitoring. So let's take a look into the nursing interventions for the pain and symptom management. The options are the following: administer morphine 2 milligrams IV for persistent chest pain, administer ondansetron 4 milligrams IV for nausea, administer lorazepam 1 milligram IV for anxiety, administer nitroglycerin 0.4 milligrams sublingual, again, if systolic blood pressure remains above 90 mmHg. So let's focus into this first category. What do you think would be the answers here? So, if you selected the first action here, which is administer morphine 2 milligrams IV for persistent chest pain, this is correct. All right. Again, the pain here indicates that there's still ongoing ischemia despite the use of nitroglycerin. And the morphine 2 milligrams IV is used to relieve pain. It can reduce the anxiety. It will decrease the myocardial oxygen demand, which is essential in STEMI. And this is a standard adjunct therapy when nitroglycerin alone does not adequately relieve pain. It also can help the control of pain-related anxiety, which can worsen the condition. So I want you to keep that in mind, that morphine has actually several drug effects to help this patient. Now, what about administer ondansetron 4 milligrams IV for nausea? Well, that is also correct, because nausea is common in MI. It can worsen patient distress, and this can potentially lead to vomiting, which may further increase vagal stimulation. It will worsen the bradycardia, and the ondansetron is an effective antiemetic that will help relieve nausea without affecting cardiac function. So it's safe to use in this case. Now let's take a look into administer lorazepam 1 milligram IV for anxiety. What do you think about that one? Take a look. Lorazepam 1 milligram for anxiety. Well, unfortunately, we're not going to select that as a correct answer. We know that anxiety is common in patients experiencing an MI, but it should primarily be addressed through reassurance and pain management, such as the use of morphine, rather than benzos like lorazepam, because this benzo can cause respiratory depression, could cause hypotension, which may worsen the patient's condition, especially in someone waiting for the PCI, or the percutaneous coronary intervention. So your focus should be on controlling the physical symptoms like pain with the use of the morphine, which can also allay the patient's anxiety before addressing the psychological symptoms. Now let's move on into the next option. Here we have administer nitroglycerin 0.4 milligrams sublingual, again if systolic blood pressure remains above 90. What do you think about this one? So like I've said earlier, this medication is actually beneficial for this patient because the nitroglycerin can work by dilating the blood vessels. It will reduce both the preload, which is the amount of blood returning to the heart, and it will also reduce the afterload, which is the resistance the heart must overcome to pump blood. And so when the preload is reduced, it will decrease the heart's workload, and by reducing afterload, it will also lower the resistance against which the heart has to pump. And so this can lower the myocardial oxygen demand, and it will help relieve chest pain. And if the patient's blood pressure is stable, which is above 90 systolic, then administering another dose of nitroglycerin can actually help improve the blood flow to the heart. And this will further relieve ischemia and also can reduce the patient's chest pain. Alrighty, so I hope that you were able to capture all those 3 correct answers. Now let's take a look into the category preparation for the percutaneous coronary intervention, or the PCI. Now the first in the list is administer clopidogrel 300 milligrams orally per protocol. What do you think about this? Well, this is also correct. This is administered, often given immediately on the diagnosis. So even before the diagnostic angiography, or let's say the PCI, is done. Now remember about the classification of this drug. This is what we call as the P2Y12 inhibitor, which is going to prevent platelet aggregation, and this is a very important step in managing the STEMI. And so if you are administering this 300 milligrams of loading dose, this can optimize the antiplatelet therapy before the PCI. It will help prevent clot formation during the procedure, and also a standard intervention in the emergency department for patients with STEMI undergoing a PCI. Now, what about ensure 2 large bore IV access sites? This is also correct, because with PCI, this procedure requires reliable and secure IV access for IV fluids, medication, the administration of contrast media, and also potential emergency interventions. Now, the 2 large bore IV access are very necessary to ensure that the patient is ready for the procedure and to minimize complications during the transfer to the cath lab. Now, what else do we have here? Ensure that informed consent for the PCI procedure is signed by the patient. Again, I missed something about the word by. So, what about this? This is also correct. So, make sure that before you send the patient to the cath lab, this consent form has already been signed by the patient, or maybe a designated person, maybe a medical proxy, before we're going to send this patient to the procedure room. And this is an important step to ensure that the patient understands the procedure, the risks, and the benefits. And this will also legally protect the healthcare provider, the team, and this will also allow the patient to participate in decision making regarding their care. Now we have the option here. It says administer furosemide 20 milligrams IV to reduce preload. Unfortunately, this is an incorrect option. And recall that furosemide is a loop diuretic, which is intended to reduce fluid overload in heart failure by decreasing preload. However, this patient does not show signs of fluid overload, such as having crackles or dyspnea. And the BNP level, 250 picograms per ml, is not elevated enough to indicate heart failure. And so the priority is to manage the myocardial ischemia, and furosemide is unnecessary at this point. And so prematurely administering furosemide could also worsen the patient's hypotension. Now, let's take a look into the next category, which is ongoing monitoring. So the option here, it says monitor ECG for resolution of ST elevation. What do you think about this one? Well, this is correct, because with persistent elevation, this is a sign of ongoing ischemia. It indicates that myocardial injury is still occurring. And so continuous monitoring of the ECG is very critical for us to assess whether ischemia is improving through reperfusion, or if complications such as a reocclusion of the coronary artery are developing. And so this will also guide further treatment and interventions, including a PCI. Now, the next option here, we have assess for signs of heart failure. What do you think about this? Well, this is also correct, because with anterior MI, which actually is reflecting the ST elevation in leads V2, V4, it's putting the patient at high risk for the left ventricular dysfunction and heart failure. And so it's very critical for you to assess for any signs like crackles, dyspnea, or a rapid weight gain may be caused by, let's say, fluid retention, because these may indicate the onset of acute heart failure. And so early identification of heart failure symptoms allows you for delivering those timely interventions to prevent further complications. Now, the next option here, it says monitor activated partial thromboplastin time, or APTT. Well, this is incorrect. We know that APTT is used to monitor patients receiving heparin therapy, which has not been initiated yet in this case. And we know that it's important to monitor anticoagulation therapy once heparin is already started, but it is not relevant at this time. And your primary focus here should be on managing the patient's pain symptoms and preparation for the PCI. Now, let's take a look into the next option. It says check blood glucose every 2 hours. Although we know that we have seen the patient's blood sugar was 180, it should be managed, but frequent monitoring every 2 hours is unnecessary during the acute phase of STEMI management. Your priority this time is to stabilize the patient's cardiac condition, manage their pain, and prepare for the PCI. And the blood glucose levels can be monitored less frequently in this setting. All right. So maybe if the blood sugar could have been 500 or 600, and if they're type 1 diabetic, then that's the time that you should be worried. But for a level of, let's say, 180, it's not really that critical for you to do every 2 hours of blood sugar monitoring via finger stick. So eliminate that one. Alrighty. So I hope that you're able to eliminate those distractors as well. Now, for this question with the multiple response grouping, what you do here is to analyze first those cues like persistent chest pain, 5 out of 10, even though it's somewhat kind of a little bit lower compared to the first pain level that the nurse had assessed. There's also nausea, impending PCI to identify needs for pain relief and procedure preparation. The next step that you should do in this scenario is to prioritize the hypothesis by focusing on ischemia management and PCI readiness, ruling out premature heart failure treatment. And the next step that you should be doing here is to generate solutions by selecting morphine, ondansetron, and nitroglycerin for symptoms, and clopidogrel and IV access for the PCI. And you need to generate those actions or take action by monitoring the patient's ECG and heart failure signs to ensure patient's stability. Now let's move forward to our next test item. We have a case here. It's a drop-down rational item. And looks like our scenario is also updated. It says the patient is awaiting transfer to the cath lab for PCI. After receiving morphine 2 milligrams IV and a second dose of nitroglycerin, chest pain is 4 out of 10. Vital signs, blood pressure 145/88, heart rate 90 beats per minute with occasional premature ventricular contractions or PVCs. Respirations 20 per minute, saturation of 97% on 2 liters per minute oxygen. He reports new dizziness. Now let's scan into the nurse's progress notes. At around 10 a.m., this was entered by the RN. It says, patient awaiting transfer to cath lab, chest pain 4 out of 10 after morphine 2 milligrams IV and second nitroglycerin dose. Vital signs BP 145/88, heart rate 90 with occasional premature ventricular contractions on monitor, respirations 20, saturation 97 on 2 liters O2. Patient reports dizziness. Clopidogrel 300 milligrams administered, 2 large bore IVs in place, consent obtained, cardiology notified of premature ventricular contractions. Now your task is to select one option from the first drop-down menu and the corresponding rationale from the second drop-down menu. So first, let's take a look into the nursing action options. We have administer normal saline 250 milligrams IV bolus, administer oxygen at 4 liters per minute via nasal cannula, prepare for synchronized cardioversion at 100 joules, administer amiodarone 150 milligrams IV bolus over 10 minutes. And the rational options are the following: to increase oxygen delivery and alleviate dizziness caused by hypoxia, to restore sinus rhythm in the presence of unstable ventricular dysrhythmia, and to suppress ventricular ectopy and prevent progression to ventricular tachycardia, and to improve preload and stabilize blood pressure in the presence of dizziness. What do you think about this test item? What would be the appropriate nursing action? Well, the correct answer to that is to administer amiodarone 150 milligrams IV bolus over 10 minutes because the patient is having PVCs. These are extra heartbeats, and during an active heart attack or STEMI, this means the heart muscle is irritated, and this could develop into a more serious rhythm problem like ventricular tachycardia. And so if you administer amiodarone, this is the right step because it calms down these extra beats. It will prevent dangerous rhythms from starting. And take note about the patient's blood pressure. It's stable, 145/88. So amiodarone can be safely given. And the dizziness that you are noticing in this patient, it might be caused by the PVCs briefly lowering the heart's output. So this medication can help fix the rhythm issue. It will improve the symptoms before the patient goes to the cath lab. Now, let's go into the incorrect options. Now, what about administer O2 at 4 liters per minute via nasal cannula? Well, this would not help because the patient already has a normal oxygen level. Review the saturation. It's currently at 97% on 2 liters per minute. And increasing the oxygen is not needed and won't solve the dizziness, which is probably from the irregular heartbeats, not low oxygen. And so this option tests whether you can recognize that normal saturation means you don't need to increase oxygen. Now let's take a look into the next option here. Prepare for synchronized cardioversion at 100 joules. This is quite aggressive. And take note that cardioversion is used for serious unstable heart rhythms like sustained ventricular tachycardia or ventricular fibrillation, not just a few PVCs. And the patient's vital signs are stable and there's no sign of shock. So cardioversion is not appropriate at this point. And so this answer checks whether you know when electrical interventions are really needed. So I hope you did not pick this option. Now let's take a look into the other option here, which is administered normal saline 250 milligrams or mLs IV bolus. What do you think about this? Well, remember about the patient's dizziness? Well, and take a look into the blood pressure of 145 over 88. It's still good, right? It's actually elevated. So there's no point to give extra fluids for this patient. And when you do this, this is actually going to cause more issue into our patient, especially in someone with a possible heart injury. It can make things worse. It can lead to heart failure. And so this option tests whether you can prioritize treating the rhythm problem instead of assuming low blood pressure or fluid loss. And so the answer for the rationale here, what's the reason why we give the amiodarone? The reason for that is to suppress ventricular ectopy, and this will prevent progression to ventricular tachycardia. Looks like I already repeated this, but I just want to emphasize that the reason why we are going to administer this drug for this patient around this time. Now, my NCLEX tip for you, especially when a patient is having new symptoms like dizziness during a heart attack, you have to check whether the issue is coming from oxygenation, whether it's coming from blood pressure issue, maybe hypotension, or maybe heart rhythm. And in this case, the issue is the rhythm. There's PVC, and that is the cause, and that's why amiodarone is the most appropriate first step to prevent worsening dysrhythmia. Now, for you to effectively, correctly answer this question, I want you to go through the steps. What you should do first is to recognize cues such as new PVCs, dizziness, which indicate a dysrhythmia during STEMI. Now, you also have to generate those solutions by evaluating actions like amiodarone versus the distractors like cardioversion or saline administration, considering that the patient has stable vitals and also the blood pressure is elevated at 145 over 88. Now, the next step that you should have done here is to take action by selecting amiodarone to suppress ventricular ectopy and to evaluate the outcomes by ensuring the rationale aligns with preventing tachycardia and not addressing hypoxia or a preload. So I hope that you're able to correctly answer this one. Let's move forward to our next test item. This is a hotspot highlight in table test item. Now, let's take a look if the scenario has updated. Yes. So let me just read through here. The patient returns from the cath lab after the PCI with stent placement. Chest pain is resolved, 0 out of 10, and vital signs are stable. Blood pressure 140/88, heart rate of 80 beats per minute, respirations 18, saturation of 99% on 2 liters per minute oxygen. The patient reports mild groin pain at the cath site. Repeat laboratory results are available. Highlight the lab results in the table that indicate potential complications requiring immediate nursing attention. Looks like we have updated nurse's notes. So around 11 a.m., it's entered that patient returned from cath lab post PCI, stent to the left anterior descending artery, chest pain resolved, 0 out of 10, vital signs, blood pressure 140/88, heart rate 80, beats per minute, respirations 18, saturation 99 on 2 liters per minute oxygen. Heparin drip started, clopidogrel 75 milligrams daily, and atorvastatin 80 milligrams daily initiated. Patient reports mild groin pain at the cath site. Repeat labs drawn. Now, let's take a look into the updated lab values here. And so your task is to click to highlight the abnormal lab results at 11 a.m. that suggest complications post PCI. So I want you to focus here on into the column around 11 a.m. post procedure. We have the following results: troponin I 1.2, CKMB 15, BNP 320, hemoglobin 12.5, hematocrit 38, potassium 4.0, sodium 137, creatinine 1.5, blood glucose of 165 milligrams per deciliter. So you can pause the video right now if you want to scan through all the columns and the rows in this slide. So feel free to do that. Alrighty, I hope that you're ready to highlight those lab results that need to be addressed. Alrighty. So the first answer that you should highlight is the troponin of 1.2 nanograms per ml. So this value has increased from 0.8 nanograms per ml. That was the result at 8:30 in the morning. And so what is the significance of this result? Well, of course, this signals that there is continued heart muscle damage, although elevated troponin is expected after a heart attack. A notable rise after stent placement may point to problems like a blocked stent, could be poor blood flow or tiny vessel blockage. And this change requires the cardiologist urgent evaluation, possibly with another angiogram or stronger antiplatelet treatment. And the rising trend makes this an urgent issue. So you got to keep this in mind. Now, what about the rest of the options here? We have the hemoglobin of 12.5 grams per deciliter. So this is a drop from 13.8 grams per deciliter at 8:30 in the morning. And so the drop in the hemoglobin combined with the groin pain at the catheter insertion site, this raises concern for internal bleeding. Again, raises concern for internal bleeding, such as hematoma in the retroperitoneal space or maybe bleeding at the axis site. And since the patient is on a heparin drip, bleeding risk is also increased. And so for you as the nurse in this case scenario, you should promptly check the insertion site. You have to monitor for any signs of low blood volume like fast heart rate or low blood pressure, and notify the provider for further testing or to consider stopping anticoagulation. Now, what else do we have here? We have hematocrit of 38%. This is also a drop from 41% at 8:30 in the morning. So this also confirms the hemoglobin decrease and also supports suspicion of bleeding after the PCI. With accompanying groin pain, this may indicate a vascular issue, and you have to make sure that you have to urgently act on this to evaluate the cath site and also to prepare possible treatment, maybe possible blood transfusion if bleeding worsens. Now let's proceed to the rest of the lab values here. We have a creatinine of 1.5 milligrams per deciliter. This is an increase from 1.3 milligrams deciliter at 8:30 in the morning. And so this also signals worsening kidney function, most likely caused by the contrast dye used during the PCI and the patient's pre-existing kidney issue. And diabetes can also increase their risk for contrast-induced nephropathy. And you as a nurse in this scenario should maintain hydration. You're going to monitor the urine output and alert the healthcare provider to adjust the medications or maybe start protective treatments like sodium bicarbonate. So those are the possible nursing actions that you can do in such case. Now, why are the rest of the lab values are not picked here? So for example, we have the CKMB 15 nanograms per ml. It's actually elevated from the previous value of 12 nanograms, right? Well, here's the reason. The increase in the CKMB is typical during an ongoing heart attack, and it does not specifically point to a post-PCI problem. And so unlike the troponin, the CKMB is not sensitive enough to detect complications like stent blockage. And so prioritizing troponin levels is more appropriate, so making this lab value less useful finding for urgent action. That's the reason for that. Now, pay attention to the BNP. It's 320 picograms per ml. It's an increase from the previous value of 250 picograms per ml. Of course, this is a big change, right? This also indicates stress on the heart, which is common after a heart attack. However, since the patient is not showing signs of heart failure like crackles or severe shortness of breath at this time, the BNP increase is not an immediate concern. And so this finding becomes more relevant later if there are heart failure symptoms developing in maybe the next few hours. So this is not really concerning this time. Now, what about the potassium of 4.0? Well, obviously that's within the normal limits. So slight decrease of 0.2, right? It might be linked to the heparin's hormonal effects, but it doesn't suggest any complication. It doesn't need immediate intervention. So this value is also included to test your focus on more serious changes. Now, what about the sodium level of 137? This is also normal, right? And the sodium levels are steady and within normal limits, and the small change does not really point to any clinical issue. It serves as a distractor. It encourages you to focus on more urgent lab trends like dropping hemoglobin or rising creatinine. Now, what about the blood glucose of 165 milligrams per deciliter? This is actually going down compared to the 180 from the lab value at 8:30 in the morning. And this is a slight drop. It's still on the high side, maybe due to the body stress response or uncontrolled diabetes. We know that glucose control is also going to matter in the long run, but this finding is not an immediate threat post-PCI. So, at this point, I want to emphasize the need for the heparin infusion after the patient had the cardiac intervention. So you might wonder, why is this patient getting the heparin drip after the cardiac intervention? Well, here's the reason. The patient suffered heart attack, and so this is affecting the front wall of the heart, which is indicated by the ST segment elevation and leads V2 through V4 on the ECG. Now, a drug-eluting stent was placed in the left anterior descending artery during a procedure, which is the PCI, right? And following the procedure, the administration of heparin drip is very critical to prevent the formation of early blood clots within the stent. So this is a foreign body that's actually placed into the heart blood vessel. And so this could lead to artery blockage and another heart attack if we are not going to administer the heparin infusion. And so the risk of clot formation is highest within the first 24 hours after the PCI, especially since the effects of the prescribed antiplatelet medications such as the clopidogrel may not yet be fully active. Even though we have already administered the clopidogrel 300 milligrams before the procedure, it's not really going to give the full therapeutic effect around this time, which is not really going to cover the patient from preventing the thrombosis. And that is why the heparin infusion is widely needed this time. And according to the 2025 guidelines from the American College of Cardiology and the American Heart Association, this is also recommended during and after percutaneous coronary intervention for high-risk patients, such as those with anterior myocardial infarction or those receiving a drug-eluting stent. And the heparin infusion should be continued for 24 to 48 hours post-procedure, and this is intended to ensure adequate anticoagulation until the antiplatelet therapy, which is the clopidogrel, becomes fully effective. And in addition to that, the guidelines from the European Society of Cardiology back in 2023, which is still active to this time, it also supports the use of heparin post-PCI in patients at high risk for thrombosis and also adjusting for the patient's bleeding risks. Now, take note that this patient has an increased risk of reinfarction due to the large MI territory which was affected by the anterior myocardial infarction. And remember, around 11 a.m., the patient's vital signs are stable with a blood pressure of 140/88 and heart rate of 80 beats per minute. So there are no contraindications for the heparin use. There's no active bleeding. There's no recent stroke. And the heparin also complements the effects of clopidogrel. This can ensure effective blood thinning during the early post-PCI period when the risk of clot formation inside the stent is at its peak. And so for you to correctly address this test item, you have to first recognize the cues by comparing the lab trends. You have to take note about the hemoglobin, the hematocrit, the troponin, also the creatinine. These are the major changes after the patient completed the PCI. Next to that, I want you to analyze the cues to identify the complications like bleeding, stent thrombosis, and nephropathy, and also prioritizing urgent findings over expected elevations, such as in the case of the CKMB. That's why we did not highlight that one. And the last step for you to answer this question is to prioritize the hypothesis by highlighting those values requiring immediate action, such as notifying the provider for bleeding or maybe renal issues, in order for us to effectively guide the nursing actions or interventions. So I hope that you're able to capture all those correct answers and eliminated those huge distractors. This time we'll proceed to our next test item, which is a matrix multiple choice item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Here, we have an updated scenario, same patient, and it says the patient is stable post-PCI for acute ST elevation, myocardial infarction, vital signs blood pressure 138/86, heart rate 78, respirations 18, saturation 98% on 2 liters per minute oxygen. At 11 a.m., hemoglobin dropped to 12.5 grams per deciliter and hematocrit to 38%. With mild groin pain noted. The groin site is now clean with no hematoma. The patient refuses smoking cessation, education, and requests early ambulation. Medications include heparin drip, clopidogrel 75 milligrams daily, atorvastatin 80 milligrams daily, and a new order for metoprolol 25 milligrams daily. Evaluate the following interventions based on safety, effectiveness, and contraindication. So that's basically not a part of the scenario. Actually it is. All right. So let's proceed to the nurse's practice notes here, entered at 12 noon or p.m. It says here, vital signs and blood pressure 138/86, heart rate 78, respirations 18, saturation 98 and 2 liters, oxygen, groin side clean, no hematoma, patient refuses smoking cessation, education, stating, I've smoked for 30 years, I'm not stopping now. Heparin drip continues, APTT pending, patient requests early ambulation. Cardiology orders metoprolol 25 milligrams daily. Your task this time is to select the appropriate descriptor, whether it's safe, effective, or contraindicated for each intervention in the matrix. So I want you to scan first the following nursing actions. You can pause this video right now before you're going to finalize the answers. All right, I hope that you have finalized your options. Let's take a look into the first nursing action here, which is administer metoprolol 25 milligrams. Is this safe, effective, or contraindicated? Well, the answer to this, it's safe. It's because metoprolol can safely be given. And take a look into the patient's blood pressure, 138/86, and the heart rate is 78 beats per minute. These are within the normal limits. There is no low blood pressure, there's no slow heart rate, and there is no evidence of complications like heart failure or conduction problems this time. Now, do you think that this is effective? Yes. This can lower heart rate. It will decrease how much oxygen the heart needs, which helps protect the heart muscle after a heart attack. And starting it early after the PCI is also backed by clinical guidelines because it reduces the risk of complications like reinfarction or arrhythmias. However, we're not going to mark contraindicated, of course. There's no clinical red flag at this time for administering the metoprolol. There's no hypotension, there's no bradycardia, so this is appropriate. And so this question challenges your ability to recognize when a medication becomes unsafe, and this isn't that time. All right, let's move forward to the next action here. Allow ambulation with assistance. Is it safe? Is it effective? Is it contraindicated? Well, for this option, for this intervention, this is contraindicated. If you're going to let the patient walk this soon, within an hour after the PCI via femoral axis, this is unsafe due to bleeding risks, especially while the patient is still on heparin and clopidogrel. And even though the groin looks fine right now, the early lab changes, there's a drop in the hemoglobin, a drop in the hematocrit, and recent PCI, which makes bleeding a serious concern here. And so I want you to understand that the best practice is to keep the patient on bed rest for about 12 to 24 hours. We are talking about PCI with an intervention, placement of a stent. This is not your regular cardiac catheterization. We know that with cardiac catheterization, there is such a wide range of bed rest restrictions, right? I hope that you remember that. But here we're talking about the PCI with stent placement. And so this is not safe. It is not effective because early movement doesn't have any therapeutic effect for the patient. It will instead raise the risk of bleeding. And so prioritizing the patient's request over clinical safety would be so dangerous at this time. So you don't allow them to ambulate this time. So brand new, fresh PCI case. Now let's look into the continue heparin drip per protocol. Is it safe? Is it effective? Is it contraindicated? Well, the answer here is safe because the vital signs remain stable. There's no active bleeding or hematoma. If you go back into the nursing documentation, although there was a small hemoglobin hematocrit drop earlier, but it's not a significant loss. Now, I want you to really pay attention to the nursing documentation here. The groin site is clean, the dressing is intact, and the normal vitals also suggest any prior bleeding is either controlled or it's non-serious. Also, the patient's kidney function is slightly impaired. There's creatinine of 1.5 milligrams per deciliter, but this doesn't affect unfractionated heparin safety. And also, this is effective. This is very critical. It's needed by the patient for the first 24 to 48 hours after a PCI, especially that he received stent placement, especially in a high-risk anterior wall MI. And so when you're going to continue the heparin drip per protocol, of course, there was no adverse reactions, right? It will help prevent those dangerous stent clots while we are waiting for the full effect of the clopidogrel orally. Now, when you are continuing the heparin drip, it supports the optimal care based on the American College of Cardiology and also the European Society of Cardiology guidelines. So that's the supporting evidence why it is very important. However, this is not contraindicated because there's no active signs or there's no serious bleeding, there's no severe thrombocytopenia, and no other conditions that would make heparin unsafe this time. And so don't forget that we're actually monitoring the patient's activated partial thromboplastin time. We're also monitoring the patient's vital sign. We're also checking the catheterization site to help manage the bleeding risk. So don't forget about those necessary interventions. And so this is mainly a distractor to check your ability to balance clot risks versus bleeding risk. Now let's proceed to the next intervention here, which is provide written smoking cessation materials. What do you think about this? Well, this is safe because when you're handing out printed information, it is non-invasive and it doesn't pose any physical risk. And it also respects the patient's right to decline active participation, but it can still offer support. And this is also effective because quitting smoking is a major part of preventing future heart problems. Even if the patient refuses education right now, the written information can still plant a seed and will possibly lead to behavior change at a later time. So don't discount that. This is not contraindicated because there's no valid reason clinically or ethically to withhold educational tools to the patient, even when the patient is not ready to engage. And so this choice also reinforces the nurse's role in ongoing health promotion despite the patient's resistance. So for you to answer this question, I want you to approach by generating solutions by evaluating the interventions in the list here, like the heparin, metoprolol against bleeding risk, and also the stable vital signs, the 138/86. And next to that, I want you to take action by marking heparin and metoprolol as safe and effective, recognizing ambulation as contraindicated due to the bleeding risk. And then after you have completed that step, I want you to evaluate the outcomes by ensuring selections align with both PCI guidelines and also balancing thrombosis prevention with monitoring for complications like hematoma. All right, I hope that you correctly answered this question. Let's proceed to our last test item. So here we have a trend, select all that apply. Now, let's take a look into the scenario here. Looks like we have a brand new documentation. It says the patient is 6 hours post PCI for acute ST elevation MI. At 1400, he reports new fatigue and mild dyspnea with fine crackles in the lower lung lobes. Vital signs of blood pressure 135/84, heart rate 76, respirations 22, saturation 95 on 2 liters per minute oxygen. The patient is on a heparin drip, APTT therapeutic, clopidogrel 75 milligrams daily, atorvastatin 80 milligrams daily, and metoprolol 25 milligrams daily. At 11 a.m., hemoglobin was 12.5 grams per deciliter and hematocrit 38% with mild groin pain noted. Review the trend in vital signs and symptoms from admission to now. Select all the priority nursing actions to address the current presentation. Alrighty, let's proceed to the nurse's practice notes. Looks like there's a new documentation to 1400. It says patient reports new fatigue and mild dyspnea, vital signs blood pressure 135/84, heart rate 76, respirations 22, saturation 95 on 2 liters per minute oxygen. Lung auscultation reveals fine crackles in lower lobes bilaterally. Groin site stable, APTT within therapeutic range. Patient repeats refusal of smoking cessation counseling. Cardiology notified of new symptoms. So your task here is to select the appropriate, actually this is not the correct instruction here. So let me get rid of that one. Let me quickly do that. All right, going back into our case scenario here. So I want you to review thoroughly the trends here. We have a trend in the blood pressure, the heart rate, the respiration, saturation, the pain score, and the notes or remarks created by the nurse. So let's go back into the 8 a.m. It says blood pressure of 158/94, heart rate 92, 22 respirations, 94% room air, oxygen saturation, pain level 7 out of 10. There was chest pain, nausea, diaphoresis, nitroglycerin, oxygen started. At 9 a.m., blood pressure is 150/90, heart rate 88, respirations 20, saturation of 98 on 2 liters per minute, pain score at 5 out of 10, pain improved, anxious, nauseated, awaiting PCI. And around 10 in the morning, blood pressure is 145/88, respirations is 20, heart rate of 90, saturation 97 on 2 liters, 4 out of 10 pain level, PVCs noted, dizziness reported, morphine given, PCI prep completed. At 11 in the morning, blood pressure 140/88, heart rate 80, respirations 18, saturation 99 on 2 liters per minute, pain score 0 out of 10, post PCI pain resolved, groin pain noted, heparin, clopidogrel started. And around 12 noon, 138/86 for the blood pressure, heart rate 78, respirations 18, pain 0 out of 10, stable, refuses smoking cessation, requests ambulation, metoprolol added. At 2 p.m., blood pressure is 135/84, heart rate 76, respirations 22, saturation of 95 and 2 liters per minute, pain score 0 out of 10, Patient reported new fatigue. There's dyspnea, crackles in lower lobes. So the following options are: administer furosemide 20 milligrams IV as ordered, increase O2 to 4 liters via nasal cannula, notify the provider to reassess metoprolol dosing, obtain a STAT-12 lead ECG to evaluate for ischemia, hold the heparin drip and notify the provider, encourage incentive spirometry every hour, administer morphine 2 milligrams IV for dyspnea, and request an order for a repeat BNP and chest X-ray. What do you think about the trend here? All right, so I want you to pause this video for you to rescan the important details in the chart, and you can proceed right after you have completed all those answers that you have generated. All right. So the first answer that we have in this test item is to administer furosemide 20 milligrams IV as ordered. Why? Well, take a look into the nurse's notes. It said there's new fatigue, there's mild shortness of breath, there's fine crackles in both lower lung lobes, and there is a drop in oxygen saturation from 98% at 12 p.m. to 95% at 2 p.m. And this indicates acute heart failure, likely caused by the left ventricular dysfunction due to the anterior ST elevation, MI. And so this information in the table actually shows that there is somewhat kind of like stable respiratory status up until 2 p.m. when the nurse detected crackles. There's also increasing respiratory rate of 22 cycles per minute from 18 from the previous 2 hours. So this is an emerging development and also a very important change in this patient. Now, take note that the BNP, the previously measured BNP, was elevated at 320 picograms per ml at 11 a.m., which also supports further presence of cardiac strain. And so when you are administering the furosemide here at 20 milligrams IV, this will help reduce fluid overload. It can relieve pulmonary edema. It can improve oxygenation, which is the priority intervention to manage the primary complication in line with the current guidelines for the acute heart failure treatment. Now let's take a look into the next option here. It says increase oxygen to 4 liters per minute via nasal cannula. What do you think about this? Well, this is correct, because the saturation of 95% along with the new shortness of breath, there's crackles, suggests that oxygenation is impaired due to the pulmonary edema, which is a consequence of heart failure. And so the patient's oxygen levels have declined from 99% at 11 a.m. to 95% at 2 p.m. This indicates the need for increased oxygen delivery. And when you increase the oxygen flow rate to 4 liters via nasal cannula, we'll aim to raise the saturation to at least 95%. It will decrease myocardial oxygen demand, and it will also enhance patient comfort. And this also complements the furosemide administration by addressing hypoxia. It will follow oxygen therapy protocols for patients with acute cardiac conditions. Now, the next answer that we have in this item is to request an order for a repeat BNP and chest X-ray. Why? It's because there is now onset of new symptoms of heart failure. There's already fatigue, shortness of breath, development of crackles, alongside a previously elevated BNP, which was already 320 picograms per ml at 11 in the morning. So this definitely requires further diagnostic testing such as checking for a chest x-ray or requesting for an x-ray to assess extent of cardiac strain and also pulmonary involvement. And so a repeat in the BNP will also help determine if the heart failure is worsening, while the chest x-ray can also identify signs of pulmonary edema, such as interstitial markings or maybe possible causes like pneumonia. And so these two tests are very critical for adjusting the treatment plan, including potential changes to the diuretic therapy or the introduction of inotropic agents, especially considering the patient's renal dysfunction. Remember that the patient's creatinine is already elevated at 1.5 milligrams per deciliter at 11 a.m., which may also complicate the fluid management. And so this approach will support accurate diagnosis and therapy planning. Now, let's explain why the rest of the options are incorrect. So, if you selected notify the provider to reassess metoprolol dosing, well, this is incorrect. This was started at 12 p.m., correct? And this can reduce the cardiac output in patients with acute heart failure. But the patient's mild symptoms such as dyspnea, saturation of 95%, and stable hemodynamics with a blood pressure of 135/84, heart rate of 76 do not suggest severe decompensation requiring an immediate change in the metoprolol dosage. There are no signs of hypotension either. There's no bradycardia in the data table. And heart failure is better managed at this stage with furosemide and oxygen. And so reassessing the metoprolol dose may be considered if symptoms worsen, maybe if the blood pressure drops below 90 for the systolic, but it is not an urgent priority this time. Now, what about obtain STAT12 lead ECG to evaluate for ischemia? Well, remember that the most recent pain score at 2 p.m. is 0 out of 10. It has been consistently 0 out of 10 since 11 in the morning post PCI. And there's no electrocardiogram abnormalities such as ST sigma changes here. There's no other or evolving EKG changes since after the PCI has been completed. And so this suggests that ischemia is not the cause of the new symptoms. And the data shows a shift from ischemia symptoms at 8 a.m. to heart failure signs. There's already crackles and a dropping saturation of 95% at 2 p.m. And so a 12 lead ECG is only critically needed if there's chest pain or if there's new dysrhythmias occurring. But managing heart failure is more urgent this time based on the current clinical findings. So I hope that you were able to eliminate this option. Now, what about hold the heparin drip and notify the provider? Why is this incorrect? Well, we recall that heparin is very necessary to prevent stent thrombosis, which is a serious risk following an anterior STEMI. And despite a mild drop in the hemoglobin and hematocrit at 11 a.m., along with a mild groin pain, the patient's vital signs and the clean groin site at 12 p.m. indicate there's no active bleeding. And so stopping the heparin drip could put the patient at risk for stent thrombosis, which is a life-threatening complication, while there is no active hemorrhage. And so we're going to continue monitoring the site of the catheter insertion, and also we're going to keep monitoring the hemoglobin levels. And this is sufficient at this point, making discontinuing heparin unnecessary this time. Now, what about encourage incentive spirometry every hour? Why is this incorrect? Well, we know that this is something that may promote lung expansion and also prevent atelectasis, but the patient's symptoms of dyspnea, crackles, and saturation of 95% are due to the pulmonary edema from heart failure, not hypoventilation. So I hope that you're able to discriminate that. And the trend in the saturation, which is the declining saturation from 99% to 95%, and the new development of crackles point to fluid overload, which should be addressed with furosemide and oxygen supplementation, not incentive spirometry, because we do not have an issue of hypoventilation. None. The spirometry does not target the underlying cardiac issue and should not be prioritized this time. Now, what about administered morphine 2 milligrams IV for dyspnea? Why was this incorrect? Well, the morphine is effective in reducing anxiety and also preload in cases of severe pulmonary edema. But the patient's dyspnea is mild. Go back into the respirations, 22 per minute, and the saturation of 95%, and there is no reported pain. The pain score is 0 out of 10. And so the administration of morphine here could lead to respiratory depression. It might inadvertently cause hypotension, which are not appropriate given the patient's stable vital signs, blood pressure of 135/84. And in this scenario, heart failure is the main concern this time, and it should be managed with furosemide and oxygen, making morphine unnecessary for this level of symptoms. Now, how are you going to approach this question if you made a mistake in selecting the options? What you should do here first is to analyze the cues like the new crackles, the dyspnea, the oxygen saturation of 95% to help determine that the patient is in heart failure, and also referencing the prior BNP result of 320 picograms per ml and the renal dysfunction. The next step that you should have done is to evaluate outcomes by selecting furosemide, oxygen increase to 4 liters per minute, and also requesting for BNP and chest X-ray to manage fluid overload, and also to confirm the diagnosis, to rule out ischemia. There's no pain, there's no bleeding because the groin side is clean. And lastly, you have to take action by prioritizing those interventions that will address heart failure while you're maintaining the heparin infusion for stent protection. Now, let's do a quick reflection about this last test item. So let's talk about what might have caused this patient's heart failure symptoms a few hours after the PCI. Well, go back into the scenario. Our patient is a 62-year-old guy who had an anterior STEMI, which is that kind that hits the front of the heart. And this is a big deal because the left anterior descending artery, or the LAD, supplies a big chunk of the left ventricle. And so when that part of the heart gets damaged, it's pretty common to see a drop in the pumping power. I'm talking about the ventricles here. And so that's probably why he's got crackles in his lungs, there's shortness of breath, and why his oxygen saturation dipped. And these are the classic signs that fluids are backing up into the lungs. Now, even though they open up the artery with PCI and placed a stent, the heart muscle doesn't always bounce back right away. So this is what we call as myocardial stunning. It's like the heart is still in a shock from the lack of oxygen from the previous hours. And so, plus we had, the patient had about 3 hours of ischemia before they could restore the blood flow, which also increases the chance of that happening. And the rising troponin level supports the ongoing injury. Now, another thing we cannot ignore is the fluid situation. He probably got IV fluids during the procedure in the cath lab, plus the contrast dye, and also remember his kidneys are already a little impaired. Remember about the creatinine level of 1.5? So he may not be clearing fluids efficiently, and that extra fluid can easily overload the heart, especially one that's already injured. And so this pushed him into mild pulmonary edema. And don't forget, there's also metoprolol. Remember that this is a beta blocker. This is a drug that is great for reducing oxygen demand and it prevents arrhythmias. But take note, it can potentially slow down the heart rate and can slightly reduce contractility. I did not say that this is contraindicated for this patient, but since our patient is already struggling, the heart, and even a small dip in the pumping strength of the ventricle, this might tip things over the heart failure symptoms. So, at this point, you might have asked, should the nurse question the provider's order to administer metoprolol 20 milligrams tablet at 12 p.m.? The answer to that question, well, there's no need to question the metoprolol order because the patient's blood pressure and heart rate were stable and are stable. He's not showing signs of heart failure, and he just had a heart attack treated with a stent. While the metoprolol could have contributed to the heart failure by slightly reducing cardiac contractility, the low dose of 25 milligrams and the stable vital signs suggest it is not the primary driver for the heart failure. And the anterior STEMI and the potential fluid overload from the IV fluids or maybe the contrast dye are more likely culprits here. And so starting a beta blocker like metoprolol is the right move based on the current heart care guidelines. And so the nurse should go ahead and give the 25 milligrams dose as ordered at 12 noon, and she has to keep an eye out for any side effects. And don't forget the client's medical history. He has a history of hypertension and diabetes for years, and so those conditions stiffen up the heart over time, and it's going to make it less able to cope with a sudden stress. And also remember that the patient has 30-pack year smoking history, and it's clear that the heart's been through a lot. And so the patient's recovery won't be easy. Alrighty. And so we'll do a quick recap of what you have completed today. So for the test 1 item, which is the bow tie, if you have completed that, you have successfully identified acute ST elevation MI, which is a primary diagnosis. You have distinguished correctly from the other conditions like the non-STEMI or the pulmonary embolism using the critical cues such as the ST segment elevation in the ECG and the elevated troponin. So if you've correctly answered that question, you had prioritized the immediate interventions such as the administration of nitroglycerin and oxygen to relieve ischemia. And you also selected the monitoring parameters such as troponin levels and pain intensity to evaluate the treatment effectiveness. And so you had demonstrated proficiency in recognizing cues, prioritizing the hypothesis, and also taking action. And so that test item really honed your ability to apply the American College of Cardiology and American Heart Association STEMI guidelines, especially in the emergency department setting. So this prepared you to initiate rapid guideline-driven care for acute coronary syndrome. So kudos to you if you have correctly answered that question. Now for test 2, that was the multiple response grouping. And so in that test item, if you correctly answer that, you effectively manage ongoing chest pain and prepared the patient for the percutaneous coronary intervention or the PCI by selecting those interventions like administering morphine, administering ondansetron, and clopidogrel, while you're also monitoring for ECG changes on heart failure signs. So in that test item, if you correctly answered that, you also demonstrated analyzing cues and generating solutions by prioritizing pain relief, nausea control, and making sure that the patient is ready for the PCI procedure over inappropriate actions like furosemide administration. So I hope that it has strengthened your ability to coordinate multidisciplinary care and also to adhere to STEMI protocols. And this has ensured comprehensive pre-PCI management. Now, moving into our third item, which was the drop-down rationale. And so by selecting the management of administering amiodarone for the premature ventricular contractions, then you have addressed a critical dysrhythmia complication. And so this allowed you to correctly differentiate it from the hemodynamic or oxygenation issues. And so if you correctly answered that, your choice reflected generating solutions and taking actions which aligned with ACLS guidance to prevent progression to ventricular tachycardia. So kudos to you. And so I hope that this item managed, or it has enhanced your critical thinking in rapid decision making under pressure, and also equipped you to manage acute rhythm disturbances during STEMI care. Now for test item number 4, which was the hotspot. So if you selected the correct options here, this helped you identify post-PCI complications by highlighting those abnormal lab values such as the troponin, the hemoglobin, the hematocrit, and the creatinine, which all indicate potential stent thrombosis, such as bleeding and contrast-induced nephropathy. So, if you selected the correct answers here, you applied recognizing cues and analyzing cues to prioritize findings requiring immediate attention, such as notifying the healthcare provider for bleeding or renal issues. So I hope that test item sharpened your ability to interpret lab trends and also act swiftly to mitigate post-procedure risks, which is critical competency in acute care nursing. Now let's move on into our 5th item, which was the matrix multiple choice. And so here you evaluated the safety and effectiveness of the interventions like continuing heparin and initiating metoprolol while recognizing ambulation as contraindicated due to the bleeding risk. And so if you selected the correct options here, you demonstrated generating solutions and evaluating outcomes by balancing anticoagulation needs with monitoring for complications, also adhering to post-PCI guidelines. So I hope that this test item refined your judgment in managing the medications and also prioritizing patient safety and also preparing you to navigate more complex post-procedure scenarios. And lastly, we have the test item number 6, which was trend test type, and also select all that apply. And so if you selected the correct answers here, you have prioritized those interventions such as administering furosemide, increasing the oxygen rate, also requesting for BNP recheck and requesting for chest x-ray. And these are used to address new onset heart failure. And so you had correctly identified pulmonary edema cues, such as the crackles, the dyspnea, while ruling out ischemia or bleeding as primary concerns. And also, you had successfully analyzed the cues and take action which aligned with the heart failure guidelines to manage fluid overload and confirm the diagnosis. So I hope that test item boosted your ability to synthesize the data trends and also implement targeted interventions for late STEMI complications and enhancing your long-term care skills. So that wraps up our Q&A today. Great job finishing the case study. So you've just practiced using your clinical judgment by pulling together patient information, the guidelines, and critical thinking to handle a changing situation. So these are the skills that will help you succeed on the NCLEX-RN and in real life nursing. So I want you to keep practicing, trust yourself, and take this confidence with you into your nursing career. So don't forget to like this video and subscribe to the channel for more helpful content. See you next time.